So, immunity is a very powerful defense mechanism, but it can also sometimes cause injury and disease, especially when it gets out of bounds or over responds. And also, whenever there are things missing, if you were born and you're not able to make the proper immune cells, that can have disastrous consequences. So, in this unit, we're going to be looking at some disorders in immunity in chapter 14. Problems with immune function can be small minor irritations like hay fever. Of course, for some of us, that's not just a minor irritation. For some of us, that is a huge deal, or just contact dermatitis. But it can also be life-threatening diseases like asthma, and if going into anaphylactic shock with things like a peanut allergy, or if you have tissue or organ transplant, graft rejection, even diabetes are some of the things that we are faced with when our immune system is not functioning properly. So we're going to be looking at immunopathology, and this is when that overreactivity or the underreactivity of the immune system can actually cause disease. Defects in the immune system, like I said, an immune system can range from a mild hay fever and dermatitis all the way to the life-threatening diseases. Abnormal immune functions here, some that we did not already list, are like rheumatoid arthritis is another one that can be kind of devastating, and we already talked about these others. So we can have hypersensitivity and we can have overreactivity. We have allergies, but then we also have something that we classify as autoimmunity, okay? So you can have tissues that are attacked by immunologic functions that don't distinguish themselves between self and non-self. And I've mentioned this a few times. Self, your body recognizes a cell's name tag, so to speak, that MHC or major histocompatibility complex or the HLA as a self. They recognize it as I belong here. So they have basically an ID tag that says they belong. Anything that is not recognized is tagged as non-self and will be attacked by the immune system. Sometimes your body misrepresents or mistags, mislabels our cells that are supposed to be there as non-self, and that is often after coming in contact with a foreign cell like a virus or something, and they get associated with that, and so you can have problems. So immunodeficiency here, this is when the immune system is incompletely developed, suppressed, or destroyed. This can be something that you are born with. Here is the boy in the bubble. I'm sorry, you can't see my mouse there. Here, over here, we have the boy in the bubble. So this would be something like SCID, which we'll get into. And this perhaps, it's hard to tell. It could be something like HIV that completely destroys a big portion of your immune system. We're going to look at the 4 classes of hypersensitivities here, okay, and classify them. We're going to have type 1, which is going to be what we call immediate. It's immediate reaction, and this is going to be our hay fever and anaphylaxis, and you're going to need to know the method of action for these. And then some examples as well. Type 2 we call antibody mediated, and this is where things like your blood type incompatibilities, like if you're positive and you're given negative blood, or if you're A positive and you're given AB, that may be a problem. Well, that will be a problem for you. Type 3 is immune complex, and this is where you get the things like rheumatoid arthritis, and it's called arthritis, sorry. It's called complex because you're going to actually have a binding between what we call complement proteins and some immune cells and the foreign antigen, okay? So those things actually can gather up and kind of sit in your joints, causing problems. And then we have our cell-mediated cytotoxic, which we often also, this is sometimes called delayed hypersensitivities on this end. So if you've taken this class before, this would be our delayed. This is where you're going to have things like contact dermatitis, but also organ or graft transplants. All right, so this slide is really important. You definitely need to know pretty much everything on this slide. I'm going to give you some more details, but I'm going to give you a lot of information right here, and then we may repeat some of it, okay? So here's our 4 types of hypersensitivities. Type 1 is immediate. This is going to be, or also anaphylactic. So this is going to be your more common allergies and anaphylaxis, all right? So allergic anaphylaxis, immediate hypersensitivity. This is going to include things like allergies to medications, like penicillin, drug allergies, eczema, different types of food allergies. We sometimes also call this IgE mediated because this is going to involve IgE antibodies. And if you'll notice here, these first three involve antibodies. Sorry, my line went off. And then this one is going to involve T cells. Okay, so this is going to involve the cells, and this one's going to involve, these are going to involve different types of antibodies. Okay, so immediate hypersensitivity. One of the important things I would like to point out here is anaphylaxis. So what do you think of when you hear anaphylaxis? Well, you're likely thinking of anaphylactic shock. Okay, so anaphylactic shock is where you have, maybe you're allergic to shrimp, you've eaten shrimp and your throat starts to close, right? You start losing your blood pressure and it's life-threatening. Truthfully, any anaphylaxis is a reaction to an allergen, okay? And so what I mean by that is, if I get stung by a wasp and I'm mildly allergic, I'm not going to go into anaphylactic shock, but I'm going to swell up and have a huge immune response compared to what someone else that's not allergic to a wasp reaction is. Okay, so if I were, say, to get stung by a bee, I'm allergic to bees and wasps, but bees much more so. I'm not going to need to go to the emergency room, but I'm going to have profuse edema. I'm going to have a lot of swelling and pain and redness at the site. My arm might swell that big around, seriously. Okay, so that is still considered an anaphylaxis. So we want to differentiate between the terms anaphylaxis and anaphylactic shock. All right, so just kind of pay attention to that verbiage because we tend to only think of the latter. All right, so type 2 is going to be our IgM and IgG mediated, or antibody mediated section here. Sorry. This is going to cause some cytotoxic cell damage. This is going to include, and like I said, I'm getting a little ahead here, but it's going to include our complement proteins binding to foreign cells. Okay, here we're going to have, I'm sorry, I'm getting ahead here. That's immune complex. We're going to have IgG and IgM binding to the foreign cells here. All right, so this is going to be where we find our blood group incompatibilities, things like anemia, myasthenia gravis. Type 3 is immune complex, and that's where we're going to have our complement proteins. We're going to have the antigen and the IgG antibodies. So you need to know which antibodies are associated with which type of hypersensitivity, okay, and what binds to what kind of triggers it, okay. And so this is where you're going to find a lot of things, like where these complexes will sit in your joints, and it's kind of like if you have pea gravel in your shoe and you walk on it for a while, it's small, but it sure does start to become irritating, right? And then lastly, we've got our type 4, which is our delayed onset or T cell mediated hypersensitivities here, okay? And so this can take time to develop. It can take hours to days, even longer than that sometimes, okay? Especially if we're talking about transplant rejection. That can actually occur months later, all right? And so we'll look at, that's also going to be like contact dermatitis, like if you're allergic to latex gloves, and it's like you wear them for a long time, then all of a sudden it seems like you develop an allergy. Well, it's not all of a sudden, it's a delayed type reaction, okay? All right, so type 1 here, this is going to be what we call our atopy and anaphylaxis type of reactions. Atopy is the inherited kind of tendency to develop allergies. So it's the genetic tendency to develop allergies. This is where you see things like asthma or eczema kind of running in families, all right? So an allergy is basically a immune response. And this is just some vocabulary words here, but they're always very important. An over-exaggerated immune response. So you have heightened inflammation, okay? So allergic people are acutely sensitive to contact with particular allergens, and that's going to be the antigen on that particular substance, okay? So that's going to cause us to have an over response there. We've got a chronic localized allergy, kind of like hay fever. It's going to be what we called atopic, all right? So like we said, atopy here. And then anaphylaxis, anaphylactic shock, I'm going to add here, is going to be this systemic reaction, okay, involving the obstruction and circulatory collapse. And that is kind of the way they are using it in the textbook, is the way we use it more in everyday language, anaphylaxis being anaphylactic shock. But truthfully, you'll find in other textbooks that anaphylaxis really is any reaction there, okay? It doesn't have to be fatal airway obstructing, okay? But in this textbook, they are using it in the more everyday language, which does make it a little bit easier, but you do need to be aware. So most of your type 1 allergic reactions are going to be relatively mild. Some things can be more severe, like asthma and food allergies that can cause death. Those are definitely going to be on the more severe scope of things. Some allergies last all of your life and actually continue to get worse during life, and some are actually outgrown, like asthma. Sometimes children outgrow that. Others, like I said, develop later on in life, okay? In the US, about half the population is affected by airborne allergies like dust, pollen, or mold. This is going to be, like I said, our inheritable type of sensitivity. You don't necessarily inherit the specific allergy, but you do inherit the sensitivity to the ability to develop the allergy, okay? So, for example, if a parent is allergic to ragweed, so to say, they may have a child that is allergic to cat hair, okay? So you develop the susceptibility to allergens. Genetically, you can pass that on, but not necessarily an allergen to a specific substance, okay? We have what we call the hygiene hypothesis, and I'm a big believer in this, and I have seen where we, over the scope of my years in raising children, and I can't remember if it started when my children were babies, which was a long time ago, or if it was shortly thereafter, they started saying, well, don't give a child peanut butter, until they're 2, and don't do this and don't do that. And then we just saw the amount of these foodborne allergies skyrocket. And so they realized that by limiting their exposure to those, they were actually causing a problem they were trying to prevent. And so that kind of falls under the don't mess with Mother Nature category for me. It knows what it's doing. Let Mother Nature take its course. Don't be overly protective. Let your kids play out in the dirt. It's going to help them develop their immune system. Seriously. So anyway, that's where the hygiene hypothesis falls in. The industrialized world has created a hygienic environment. We have all these, it's not just our mentality either. We have all these antimicrobial substances and hand soaps and very well insulated homes with very low allergen loads in them. So our immune systems, part of our immune system has to be trained, right? We've got that part of our immune system that we're born with, those innate defenses, but we have those acquired defenses that we have to pick up. And if we keep everything in our environment perfect, we're never going to pick them up, okay? And so that's where we have to not be so hyper vigilant, okay? So it's actually even been shown, well, let me go back up and say this. Your immune system basically has got to be trained by interactions with microbes as we develop, okay? So that's why I say let your kids play outside of the dirt. It's not going to hurt them. It's good for them. It's been shown that children who have grown up on farms actually have a lower incidence of many types of allergies, okay, because they're exposed in small amounts over a period of time, and so they develop their immune system in that area, okay? Interestingly enough, also, delivery by a C-section and a maternal history of allergy actually can increase the childhood risk of allergy by a factor of 8 because they're not picking up those normal microbiota as they're coming through the vagina. All right, strange to think of, but it's true. Breastfeeding is a great benefit to your child, not only immunologically, but in many other ways as well. It's actually been found that children that are breastfed for the first 6 weeks of their life have better cognitive function later on. Their brain actually grows a little bit better because your body knows exactly what your baby needs and is designed to deliver that in the best method. But not only are you giving them the nutrients they need, you are sharing your immune system with babies, okay? That's another thing I have noticed. There seems to be this hypervigilance of parents not wanting their families to come in and kiss the baby, not wanting them to touch them. But again, that hypervigilance can actually be problematic because you're not getting that shared exposure from your family, your siblings, your grandparents, your mother and your father, and also, of course, through breastfeeding, you're not getting those sorry, I'm drawing a blank here. There's normal microbiota. And so breastfeeding is the most important thing for the baby's immune system that you can do, honestly. Much more important than keeping everything clean and sterilized. Not that that's not important in some ways, okay? So they have a much lower risk, you can see, of developing things like asthma and eczema, all right? We have cytokines. Remember, those are chemical messengers and growth factors that are actually in the milk that act on the baby's gut and mucosa to induce or to cause to develop a tolerance to specific allergens. The Human Microbiome Project has found that about 600 different species of bacteria are transferred to infants through breast milk. And again, that's not a bad thing. Remember, these are important normal microbiota. We've got so much research showing us the importance of the microbiota in normal gut health and how it affects the whole organism. Okay, this is really important to development of tolerance to different substances so that you do not develop allergies to them. So you know, this can be a touchy issue for some people, the breastfeeding, but this is really a wonderful thing that can be done for a child. So why are some microbes normal inhabitants of some areas but problematic when they come through others? And how do they get through others? Okay. And so if they don't normally dwell there, they can become what we call an opportunistic pathogen. Well, and that's when they're able to find a portal of entry that they normally aren't going to an area they normally aren't in. And it also relates to what particular microbes affect what particular systems, which is what we're going to be doing in the last 2 or 3 units. I think it's 2 more units. The last 6 chapters or so, you're going to see why understanding what this portal of entry is very important. We're going to have portals of entry and portals of exit. So how does the pathogenic bacteria get into our system and affect us? Okay. So they typically enter through the epithelial portions of the respiratory tract, the mucosa of the gut, and like I said, the mucosa also of the respiratory tract. All right. And so mucosa is a thin, moist surface. It is normally pretty penetrable, or your epithelium is, okay? But we do have some defenses here. Your skin is supposed to be somewhat dry and tough. It has keratin protein in there. It's been keratinized, so we've got those layers of thick dead tissue that are kind of packed together. That helps to make it less permeable, okay? So it makes that single layer of epithelium. Now it is a stratified layer and it's all squished together, so it's much harder to get through, all right? And so access there is going to occur through tiny breaks in the skin, glands, or hair follicles. And so we also have different ways that things can go in, like is it ingested, is it injected, or is it a contact allergy, okay? So airborne allergies like pollen, dust, pet dander, fungal spores, these are what we call inhalants. We inhale them, we breathe them in. Ingesting is going to be more something that you eat, okay? So that's something that's going to cause a food allergy. Injectants are going to be like those bees or wasps I was talking about. Medications, vaccines, okay? And then a contact allergy is going to be like I had one of my children was very allergic to laundry detergent. So that was a contact allergy. Any allergy, anywhere the skin was, if we did not use the baby laundry detergent, we would have horrible red, itchy, raised rash. Okay, very uncomfortable. So that's going to be a contact allergy is one that enters through the skin. Many of those are going to be a type 4 or delayed onset hypersensitivity. Okay, so we have mast cells and basophils that are active in a type 1 allergy. Mast cells are going to be in the connective tissues, but you're going to find them in a very high percentage in lungs, GI tract, skin, and the genitourinary tract, all right? Each of these cells carries 30,000 to 100,000 cell receptors that can actually bind to IgE, which will cause them to degranulate. Okay, so remember our cells there from our white blood cells, or different types of white blood cells. We had the granulocytes and the agranulocytes, right? So in those granules are actually things that these cells use to do their job. And so this particular one, IgE, and IgE, you're going to see elevated in things like parasite infections, and allergies. So you got the E there. They're going to release cytokines, and cytokines are those chemical messengers that can cause complement to start, which is going to be releasing or causing, triggering inflammation. And that's where the symptoms of our allergy actually come into play. Okay, so this fancy sentence down here that says the physiological effects of mast cells derived allergic mediators on target organs. It just means these cytokines that are going to the areas that you're going to have inflammation show up. So that's where you get the stuffy nose, the tears, the itchiness, that type of thing. So here we're going to look at a type 1 allergic response. Over here on the left, we're looking at sensitization, okay? What happens when you become sensitized? You have to get a dose large enough to allow you to become sensitized. And so having very small, tiny amounts is actually how we do things like the allergy testing, not allergy testing, but getting allergy shots, okay? That's how that works, is you get a very small amount. It's not enough to cause you to do these subsequent steps, okay? And so in A, you are sensitized. That dose that's large enough comes in. The lymphatic vessel is going to carry the allergen to the lymph node. Once it is in the lymph, your B cell is going to recognize that allergen with the T helper cell's assistance. And then it's going to proliferate into plasma cells. Okay, it's going to make many, many copies, and then it's going to differentiate into either plasma cells. And then those plasma cells are going to make your IgE antibodies, all right? So it's just you're gonna get both of those out of that response. You're gonna get plasma cells and IgE antibodies. And so let's see, we are now on number 6 here. Your IgE is going to bind to the mast surface cells once you are exposed again. Okay, so the next time you're exposed, those antibodies are going to bind to your mast cell receptors. All right, and then the allergen is going to attach actually to the IgE on the mast cells, and then it's going to cause this degranulation here. So these chemicals are going to be released into your bloodstream, and so that's going to be your allergic mediators, all right? And so in this case, we said it was cytokines, and what did the cytokines do? They cause inflammation. You're going to have blood vessels dilate. You're going to have restricted bronchioles here, okay? You can get a headache because your nerve cells are being stimulated there. You're going to have the release of leukotrienes, all right, and that's going to cause constriction of your bronchioles and obstruction of your airway with a little mucus buildup there. Histamine, serotonin, and bradykinin are all going to be released, and that's going to increase blood flow, dilate blood vessels, okay, and that's where you get that pressure feeling. And you're going to have increased peristalsis, you can have in the intestines, diarrhea, which will cause diarrhea or vomiting, depending on the level of that. And you can also have increased secretion. So what does that mean? The runny nose, okay? So that's kind of how all that works together. So here are these 3 chemical mediators here, histamine, bradykinin, and serotonin. All right, you need to know the effects of these and the leukotrienes. Histamine is going to cause constriction of smooth muscles of those bronchi and intestines, but it's also going to relax vascular smooth muscles. You can see those wheel and flare reactions when someone has a allergic response and you see those little wheels on them. That's kind of a classic sign that you've got a pretty good allergic reaction going on. You're going to have pruritus, which is itching, headache. Serotonin, we don't completely understand the role, but it seems to actually complement histamine and bradykinin. So bradykinin will prolong or increase the length of the smooth muscle contraction in the bronchioles. You're going to have some dilation in the peripheral arterioles, which are more towards the outward side of the body. You're going to increase the permeability of the capillaries, and so they're going to be able to pull things in more. And you're going to have more mucus produced as well. So leukotrienes take a little bit longer to come into effect here. They will gradually cause a contraction of smooth muscles, make your bronchospasms last a little bit longer than they should, increase, again, vascular permeability and mucus secretion, okay? So this plays an important role with the other 3 that we just looked at for somebody that has asthma, okay? It's also going to stimulate, which means cause the production of more polymorphonuclear leukocytes, okay? So it's going to stimulate production of white blood cells. And then we have prostaglandins. These also help to regulate smooth muscle contraction. This is actually, prostaglandins are usually active during things like uterine contraction and delivery. And so we have to understand that prostaglandins, even though they're more associated with that type of thing, they play another role. Just like serotonin, we tend to think of as just a feel-good chemical, but it also plays a role in healing in skin. So sometimes these chemicals have more than one job to do. All right. So prostaglandins can cause vasodilation, increased permeability of those blood vessels, increased pain reception, bronchoconstriction. All right. NSAIDs work really well to inhibit the action of prostaglandins, so they're very good to work against the symptoms and help us to feel better. All right, review question here, NCLEX practice. During a visit to his physician, a patient is asked about his allergies. He reports that a generalized raised rash following a dose of an IV antibiotic. So what type of reaction is this? Is it A, immediate hypersensitivity, B, antibody mediated, C, immune complex, D, cell mediated, or is it just a side effect? If you said A, immediate hypersensitivity, you are correct. Most of these drug medications are immediate hypersensitivities. Hay fever is just kind of a generic everyday term that we use for allergic rhinitis. And so this is a seasonal reaction to several different things, okay? And so unless you've had allergy testing, it's not necessarily aligned with hay. That's just when people normally would see it, and so they all thought it was due to the hay. And so this is inhaled plant pollen, often in molds. Sometimes it's chronic, but this is usually going to be a more seasonal type of allergy, okay? And of course, the target's going to be the respiratory membranes. The symptoms are congestion, sneezing, coughing, runny nose, itchy, red, teary eyes, and some bronchoconstriction. So asthma is a common childhood illness, and it's a respiratory disease where you see episodic problems with breathing being limited and severe bronchoconstriction. And there is a spectrum of disorders here. You can go from reactive airway disease, which is kind of like a cough variant type asthma, all the way to life-threatening full-blown asthma where you're having asthma attacks. So the airways of asthmatics are very sensitive to just a very small amount of inhalant here, okay? You can, like I said, have a range from labored breathing to complete constriction and suffocation. You can have what we call rales. That's often a descriptive term used for a rattling sound of the lungs. And what triggers this is an overreaction to those leukotrienes and serotonin, okay? Natural killer cells can also be recruited and brought in and activated. The leukotrienes there, they actually act to cause a prolonged bronchospasm. They cause vascular permeability and increased mucus secretion, all right? Bradykinins, leukotrienes, and serotonin are all going to cause symptoms of chest tightness, wheezing, overexpanded lungs, and excessive coughing. So you may be wondering, why do we need to know what particular chemicals are causing what? Well, you may recognize leukotrienes from a commercial for an asthma medication. This is how we develop medications, okay? If we know what substances are causing what part of the reaction, we can find a medication to block that particular substance, okay? Singulair is the one I'm talking about that actually blocks leukotrienes, and I know that because that's actually one that I take for my issues. But just kind of an important thing to think about, that there is definitely a reason why we need to know this information. Let's see. Actually, this is kind of a duplicate of the other. I'm going to leave this, though, because that first part of why we need to learn this is kind of important. All right, so atopic dermatitis and eczema, all right? Pretty common condition. You have itchy, inflamed skin. You often have a rash. These are some pretty severe cases here. This is a vesicular rash with encrusted lesions. It does not always get crusty like that, but it definitely can. Sensitization occurs by ingesting, inhaling, or contact with allergens on the skin. Usually this begins with the baby, okay? You get really red areas, you get that vesicular rash, and then as it progresses, you get the scaly, thick condition, okay? Lesions are itchy and very, very itchy and painful, and can easily develop a secondary bacterial infection, especially in children because it's just hard for them to not scratch. And their hands aren't very clean. Okay, so food allergies. The most common causes of food allergies are going to be fish, peanuts, milk, eggs, shellfish, and soybeans. I would say soybeans probably due to the high incidence or use of them, but that's just a guess, okay? So the mode of entry here is for new food allergy is going to be intestinal. Symptoms include vomiting, diarrhea, abdominal pain, although you can get those hives, which is the wheal and flare I was talking about earlier, rhinitis, asthma, and occasionally that anaphylaxis reaction where it can be life-threatening, okay? So again, allergies, think IgE, and this is going to involve the degranulations of the mast cells, but there are other things that come into play here, all right? And so this is really important for people with vaccines because often vaccines will be have egg-related products in them, and so that's always a question for people who have to get vaccinated. Different vaccines. It depends on which one we're talking about. So drug allergies are actually the most common side effect of chemotherapy or treatment with medications, affecting 5 to 10% of hospitalized patients. These can be pretty bad pretty quickly, okay? So again, this is type 1. It's the allergen is not the intact drug itself, but the hapten or epitope given off when the liver processes the drug. So it will take a little bit of time to show up, okay? So these reactions can be very mild, and they can also very quickly be life-threatening, and you're going to have everything in between. I've had some of these sulfa drugs where I had a really bad rash. I didn't have any fatal issues with it, but I did have neurologic complications that lasted for like 6 months. Okay, very strange. There's different types of things that can happen here, okay, than generally what we're thinking of. So penicillin is, of course, the most common. Sulfa drugs are synthetic, they're man-made, and those are a very common issue as well. Then we have aspirin, opiates, and then the IV iodine type contrast dye that's used with MRIs or X-rays, okay? Another one I'm very lucky to be allergic to. So yeah, you will see a range of these, and then of course there are some people that are allergic to many different antibiotics. My mother is allergic to almost every antibiotic out there. All right, so you do have that genetic predisposition, and of course, how often you're exposed, that type of thing is going to play a role in the process. All right, so anaphylaxis is that very quick reaction to an allergen. It's an overpowering of the IgE-mediated allergic reactions, all right? Bee stings, injections of antibiotics or serum, most common causes of this, all right? Causes circulatory disruptions. It can cause tachycardia, okay, elevated heart rate, low blood pressure, which is what shock is. You basically losing your blood pressure, swelling of the lips, tongue, or throat, of course, and then those wheal and flare reactions, arrhythmia, which is redness of skin. And so we have some different types. We have cutaneous anaphylaxis. Okay, that's the wheal and flare. That's the local type of reactions, the local injection of an allergen like a bee sting. Systemic is the life-threatening anaphylactic shock where you have sudden respiratory, circulatory failure and can be fatal in a very short period of time. And these are the people that are going to need to carry around with them an EpiPen or something like that, because this is life-threatening in a very, very quick way. All right. All right, so how do we diagnose allergies? All right, we have our in vitro methods, and these are things that are going to happen outside of the living organism. So we have the RAST test, which is the radioallergosorbent test, and that actually measures your IgE antigen. So remember, IgE, parasites, protozoans, right? Parasites and allergies, okay? Tryptase test. This is going to measure tryptase, which is an enzyme that's released by mast cells during allergic response. You can do a differential blood cell count and look at the basophils and the eosinophils, okay? And then you can also do leukocyte histamine release test, which is going to measure how much histamine is released from the patient's basophils when it is exposed to a particular allergen. Also have in vivo methods, which are done in a living organism. Okay, this is to find out exactly what you are sensitive to. All right, so if you have a reaction within 20 minutes after you insert the antigen, that means you've got histamine being released. And then they're going to measure the diameter of that to kind of score how allergic you are to certain substances. Now, not shown on this picture, you generally are going to have two controls. You're going to have a positive control and a negative control. Your negative control will be like saline solution, and your positive control will be histamine, because you're going to know you're going to get a response to that. Okay, and so you can kind of see here on the skin they've ingested different things, and so maybe you have here acacia gum, cat dander, chicken feathers here, cotton lint. All right, and then down here maybe you have I don't know, mohair paper. That's an odd one. Pyrethrum or this ozite. Okay. And then up here, there's going to be some more. And so this is where they basically go and do what we used to call a scratch test and see what you react to. Okay. And so then this is classified here. You've got not done, the blue is no reaction, going all the way to red, which is a severe reaction. So treatment of allergies is going to be desensitization, sorry. And so this is where this is when we're not treating just the symptoms, we're actually treating the allergy. So this is going to be where you inject a very small amount of allergen under the skin. Like I said, you don't reach the sensitizing amount. You got to be below that level there. Okay, so you are below that level, and it induces the formation of IgG antibodies that bind to the allergen before it's able to bind to the IgE ones. All right, and so you kind of get just enough exposure to get a response, but not a complete response. Okay, and so you can see that here. Blocking the events in an allergy. Okay, avoiding the allergy. So this would be medications. All right, so this is like if you have a poison ivy reaction. My daughter can drive by a field that's being burning something with poison ivy near it, and she'll just completely break out all over. Has to go on steroid injections. Injections and long-term medication for a few weeks. Okay, or antihistamines. All right, so this is showing you treating the symptoms basically. All right. Avoiding the allergy, so that's like if I'm allergic to penicillin, I won't take it. Like I will never take sulfa drugs again. I can promise you that. Or desensitization. Sorry, I tried to say it too fast. And that's your classic allergy shots. All right, that's going to give you the long-term relief.